Hello, good evening. Dr. Samina Bilal here. Most of you know that I am with Multifocal University since 2016. First as a student, then as your coordinator, you can say instructor. So this examination I have designed in a way that all the tricky question in interior segment, which can give some problem to the students, they are covered. So without any delay, let's start. There are 14 questions altogether. I don't want to force anyone. You can volunteer on your own and try to reply as many questions as are possible. So any volunteer, I'm going to start first question. Let me remove these icons. Okay. So this is the first question. Describe this picture. Anyone?
Okay.
Mariam, you were the first who, whatever. Oh, Heba, you want to answer? Yes.
Yes, please. I can see an anterior segment photo with the elimination of parallactical elimination. I can see intumescent cataract with liquefied cortex and brown nucleus.
So what is this? Isn't there any specific term for this kind of cataract?
Hypermature cataract.
Hypermature cataract. There is another name for that, hypermature cataract with nucleus downwards.
Intumescent.
Yes. Okay, but my question is, how do you know? Imagine this white part is calcified posterior capsule, or how do you know this is a subluxated lens, or this is in fact hypermature cataract with nucleus drifted downwards? Is there some way you can confirm it on examination?
If it is subluxated lens, I can examine the anterior chamber. There will be an equal anterior chamber, or I can see phacodenesis or iridodenesis.
Correct.
And I can see sometimes I can see the zonules.
Yes, you can see zonules. There is another thing. Have you heard of triangle sign?
Yes, there is a triangle sign that can be seen in this type of cataract due to dropping of the nucleus like this.
Okay, so what is basically triangle sign?
Triangle sign. It is a triangle.
Why do we get to see the triangle sign?
We do parallactical elimination. And the anterior capsule and posterior capsule and the liquefied cortex in between, and the base of this triangle will be the nucleus.
Yes. So those who are not very familiar, look at this picture. In figure 2, zonules are not intact and whole nucleus is subluxated downwards. But if you get to see the triangle sign, in the point A is where anterior posterior capsule has been fused, and you get to see this small triangle there. Okay, well done. Heba, now my question is, this patient comes to you, neglected patient. This patient still says that he doesn't want to get the procedure done because he's comfortable with the other eye, whatever vision he or she has. What are the problems that can happen if we do not treat this patient, this eye?
The problem can be phacolytic glaucoma or mostly phacolytic.
Phacoanaphylactic?
Anaphylactic.
What is the difference between two? Phacolytic and phacoanaphylactic?
Phacoanaphylactic is due to
proteins releasing into the interior chamber, causing inflammation and leading to high IOP. That is phacoanaphylactic. And phacolytic is just those proteins trapping into the trabecular meshwork. Okay. So what else?
Also another type is phacomorphic, and also
this can rupture directly into the anterior chamber, right? Okay, yes. Correct. So,
And also, if
so
there is any problem,
okay. So, Hiba, what is the pre-op assessment and what is your treatment plan for this patient?
my treatment plan for this patient, I wanted to do I want to counsel the patient about the importance of cataract removal.
Yes.
And I have a problem that the fundus cannot be examined well, so I need to do P scan to examine the fundus well, and look for pupillary reaction and do light projection from 4 quadrants, and then I'll examine the patient well, including extraocular motility and IOP. Intraocular pressure and anterior segment and any signs of uveitis. I'll do biometry, but it may be difficult by IOL master, so I can use a scan to get the axial lens.
Good. So you're going to operate on this case, right? After controlling IOP. Is that so?
Yes. Yes.
So by what method you will take out this cataract? Or what will be your surgical technique? Will you
I
do
can
extra
do
cap
yes,
or phaco, or what will you do?
I can start by doing phaco. Yes, I'll do phaco.
Any during, okay, so you are planning phaco on this case. Do you expect any challenges in this case?
Yes, I
doing
have a lot
phaco?
of challenges because this type of cataract, a swollen lens may cause a weak anterior and posterior capsule. So during rhexis may extend, or there is high probability of posterior capsule rupture, and also zonules are weak due to long-standing cataract. Also, I have to protect endothelium, so I have to use soft shell technique and excessive visco elastic. When I start doing rhexis, I can aspirate some of cortical material before starting doing rhexis, and I'll do rhexis by little technique. Start small rhexis and then enlarge it step by step. And I'll consider preparing 3-piece IOL, and also I
Okay,
restore.
Hiba, let me interrupt. Since this phaco surgery is full of so many problems, you said enumerated all these problems. You can have problem in rhexis and everything. Is there some easier way you can take out this cataract? There are so many ways available, right?
Yes, extra capsular or a small incision.
Minimum small incision surgery. And while putting IOL, can you do something which can make this procedure comparatively easier? Like IOL scaffold method, like you put IOL first and then you take out the cataract, the nucleus with it. Okay.
Okay.
Am I clear? Correct. So you have done replied very well. Whatever answer you give, you should be able to justify that. Okay. So correct.
Thank
okay.
you.
Now we are going to the next question. Okay. Who is taking this question? Who wants to take this question? Maria?
Okay, ma'am, I'll take, ma'am. I'm Dr. Arshi. I'll take it.
Okay. So the question is, a construction worker had a splash of paint in his eye and is rushed to the hospital, to your clinic. First, what is the first line management you will do this patient before you start examining it?
Ma'am, I could not. Yeah, can you please repeat this one? What is the initial management?
So construction worker had a splash of paint in his eye and is rushed to your clinic. Okay. What is the first line management? What will you do the moment patient comes to your clinic?
Yeah. So the first line of management is to wash his eyes with copious, if available, distilled water, it is better. Otherwise, the normal tap water also can be used. Wash the eyes, and then we will check the pH. Depending on that, we will start, we will come to know that, okay, this is acidic or saline pH. Depending on that, we can think of what would be the management.
So
Then
basically,
we
you
will
will
check on
you will wash the eye till it's neutralized. You get the neutralized
yes,
pH, right? Is that what
yes,
you're saying?
yes.
Correct. Okay, so what are the key features that determine the prognosis of a chemical injury? First, tell in history and then on
Okay.
examination.
Yeah, so the history he has told that already he had a splash of paint. So paint mostly they can be alkaline. I think so. They can be alkaline.
It
They will
is
be.
alkaline.
So
So which one is more dangerous, alkaline or acidic?
alkaline is more dangerous because
Okay, so
acidic forms a covering of protein coagulation, which helps in not penetrating the acid inside the eye.
so in this patient,
So,
what other factors?
so I have to check for the ischemia. I have to check for the corneal haziness. I'll grade the ischemia. Depending on that, we will classify it as mild, moderate, or severe. If ischemia is in less than one third, and or the ischemia is between one third to half, or if it is more than half or full. So this is according to ischemia, which we will see in the limbal blood vessels. And the other thing is we can also grade according to the cornea visibility, AC visibility. So
So there is a classification, right?
yes, yes,
Arshi, there is a classification. Do you know
yes,
what
yes.
classification system is used to classify the chemical injury? Name those two
Yeah,
classification systems. This is very important. You're
yeah.
telling correct.
So yeah. So the classification name, I don't remember. Maybe it
One
is
is Roper
Rob.
Hall. The one
Yeah.
you are telling
Okay.
where we take into account limbal ischemia and corneal clarity, that is Roper Hall classification.
Okay.
Other is Dua classification, that is according to the number of clock hours. Okay. So there are
Yeah.
four
Okay.
grades. There are four
Yeah.
grades. What
Yes.
is grade one? You said according to
One
that,
third.
I will
Less
classify.
than one third. Yeah. Okay.
Grade one is minimal limbal
Less than.
ischemia, just corneal
Yeah.
epithelial haze. Okay.
Yeah. Okay.
Now tell grade two.
Between one third to half, and the cornea
Less
AC
than one
details
third.
are a
No.
little bit hazy.
Grade two is less than one third. Grade two is
Less than one
less
third.
than one
Okay.
third,
Okay.
right?
Okay. Yeah. Yeah. Okay.
And grade three
Less than
is
one third.
one third to half with marked corneal opacification, and grade four is total opacification, more than half limbal ischemia. So the biggest prognostic factor is limbal ischemia. The other classification you can memorize that I have added that slide, that is Dua classification, that is according to the number of clock hours, but you must know
Okay.
the names of classification system, and you
Yeah.
must know at least one system which you know. Okay. So okay, so
Okay.
you have told me the grading system. Now you tell me, what is the management plan for this patient? What will you do now?
So yeah.
It is
So
grade two.
management plan. If it is grade 2, that means it is less than one third, and of the ischemia is there, and the cornea is a little bit hazy. So after washing, then we will give the patient antibiotic and steroid combination, and we will check whether we'll put first the fluorescein. Before fluorescein, we have to check the visual acuity. All that examination we need to do it. Then after visual acuity, we will see what is the level of ischemia and all that thing we have recorded, and then we will start the IOP. If it is possible, we should record the IOP also,
But grade
and
two you won't
AC
be able to,
reaction.
because okay, but correct. By puff tonometer you can measure. Yes. What
Yeah, we can
else?
measure with ear puff. And uveitis, we have to check if there's any uveitis. After that, we will start with the antibiotic and steroid combination, because we want to reduce the inflammation as much as possible, and we will give lubricants. We will give cycloplegics, and if pressure is high, then we will start with some anti-glaucoma medication.
Which one?
Um,
Which one preferred?
mm, we should not give prostaglandins analog, and we should not give this dorzolamide, I mean this carbonic anhydrase, because we don't want endothelium to have any effect on endothelium. It can, so we will give either beta blockers or
Anything
we
oral
can give
you
alpha
want to
gram,
give?
brimonidine.
Any oral medication?
Yeah, alpha adrenergic agonist is better option.
Okay, so other than that, to promote healing, anything oral you want to give?
Yes, to promote healing, we can also give some doxycycline, OMI, and then this
What
is
will
that?
doxycycline do? It is
It helps in the healing in the way because it has a two effect. One, it is antibiotic, but the other thing is that it inhibits the lipases. So it
is
um,
anticollagenase. It has anticollagenase activity. So yes,
yeah,
so it will
yeah,
promote healing. Okay, and
anticollagenase.
you can
Yes,
give
yes,
oral
yes.
vitamin C as well. What
Yeah,
else?
oral vitamin C.
What else? So it's
Cycloplegic,
grade
I have
2,
added.
1/3 to
Yeah,
half limbal ischemia. It's severe injury. Anything you are
yeah.
preempting in the long-term cases? Like anything you want precautionary you want to give?
If it is an epithelial defect is there, then we can just give some.
Okay,
I
I'll ask
mean,
you
we can
another
give
question,
BCL,
and you will
bandage
automatically know. What are the problems,
Yeah,
complications
yeah,
you expect in a
yeah,
patient with chemical injury?
yeah,
So severe, what are the problems you
yeah.
expect?
Yeah, so these injuries can lead to adhesions in the symblepharon formation can also happen,
So,
and
so in the
limbal cell
treatment, what will you
dysfunction.
do? So, Arshi,
Amniotic
back.
membrane can be given, or
Uh,
limbal cell
Before
transplant
that,
can be done.
when you are giving the primary treatment, Arshi, when you are giving the primary treatment, you are giving everything, and it's symblepharon can be formed. What can you give?
Yeah.
Scleral rings can be given.
What,
Or you can
ma'am?
give scleral rings, or sometimes you just give that
Yeah,
glass rod and we
yeah.
ask them to just
Glass rod, yes.
pass
Yes, ma'am.
through
Yeah.
to break any kind of adhesions. Please don't
Yeah.
forget. Okay, this is very
Yes.
important. So what are the
Yes.
complications? Yes, the
Okay.
limbal stem cell deficiency, which can lead to
Yeah. Limbal cell deficiency lead to ma'am, recurrent corneal erosions, non-healing cornea.
and dry eyes and non-healing
Dry eye, yes,
cornea,
dry eyes.
which can
Sicca.
lead to
Yeah.
then corneal melting and all these
Yes.
opacity.
Yeah.
There can be glaucoma and UVI.
Yeah.
Correct.
Okay.
Okay, so
Yeah.
just one
Yeah.
question. When you are washing the eye with in chemical injury,
Yeah.
what is the preferred solution? Like
Yeah.
you are given shown some solutions that these are available. Which one is preferred to wash the eye? Hyperosmolar, hypoosmolar, or whatever? And why?
0.9% sodium chloride is okay.
Basically, you have to give isotonic.
ISO.
You don't
Yes,
want to wash
isotonic.
the eye with hyperosmolar or hypo because you want to keep the integrity of cornea intact. So you will preferably, like you said, we can just wash with tap water. That is better than any other solution. Or if you have any solution, it should be isotonic. Okay.
Okay.
To the car.
Yeah.
Good.
Okay.
So good. So I think we are done with this question. This is the classification. Okay. When you will see this again, you must read. You must know the names. That will give immediately like good points to you that you know the classification. Otherwise, you have mentioned correctly. Now, this is the third question.
Okay.
Who will take this question? Anyone?
Yes, madam.
Okay. Who is taking this question?
I'm Mariam Fathi.
Okay.
An 18-year-old.
I will read the question. An 18-year-old boy is a known case of BKC, vernal keratoconjunctivitis. He complained that he is unable to get satisfactory glasses for some years now. When you check his best corrected visual acuity, it is -6 spherical with -4 cylinder at 20 degrees, vision is 6/9, and -3 with -2.50 cylinder at 150 degrees, and vision is 6/6 partial. Based on this scenario, a 18 years old person with BKC, what is the first thing that comes to your mind and which you would like to rule out?
First of all, I want to rule out keratoconus.
So basically, you have in mind that this person may have keratoconus. Okay. So now tell me, what will be your approach to this patient? How will you assess, and what will you do about it?
Okay. First of all, I will assess the patient with anterior segment. I can elicit some findings of keratoconus, like scissoring of the retinoscope, oil droplet sign. I can elicit also Vogt Stroya, Fleischer ring, reductive sign by sclerotic scatter. I should perform that his vernal keratoconjunctivitis is more or less stable. I should examine his fundus well. Also, I would check for his refraction by doing cycloplegic refraction. Another trial maybe in another session. Okay. Then if these all are okay, I would prescribe. I would order a pentacam or a corneal tomography. I will ask for family history also, and his one of his sisters or brothers has something like this. Okay.
So important thing is you may not find all these clinical signs in a patient who may have early keratoconus or even slightly more so. You are perfectly fine. You are right, absolutely right, in keeping in mind that you are looking for keratoconus and mentioning that you want to see pentacam. So now this is the pentacam of this boy.
Okay.
What do you see? Look
Okay,
at this and give me diagnosis. In like, you don't need to like mention all of the things. Just mention few things based on which you are giving your diagnosis. So what is this?
Okay. First of all, the QS is okay, so I would depend this pentacam is reliable. Okay. On looking at the axial or sagittal curvature, I have no bow tie. No bow tie at all. There is skewing, and there is I can't elicit this skewing, and I can't judge the inferior to superior steepening. The K reading are the flat is -7, and the K2 is sorry, I'm sorry. The K1 is 50.7. The K2 is 51. K max. K max
is 58.9. K max is 58.9.
Yeah, so this is above normal. This in the first picture, which is the axial sagittal max. This indicates keratoconus. I can see the thinnest location, the pachymetry apex. It is 410 micron. Sorry, the thinnest location is 401 micron. The pachy apex is 110. It is shifted around 9 micron, which is more or less suspicious.
So basically, this is so. What is your diagnosis? What is this? This boy has.
I think this is a keratoconus grade.
Would you like to see the second part of that?
Yeah.
So now looking at this, what is your diagnosis?
Yes.
You're correct. I'm just telling you from exam point of view. Listen, you're absolutely right. You suspected it's keratoconus when you are shown a pentacam along with you have findings or not. When you get this kind of pentacam, you should be absolutely clear that this is keratoconus. You don't say it can be. If you say it can be, I'll ask you what else. If it is not keratoconus, what do you think it is, right? So this is as clear as day and night. So you can say this pentacam, based on those findings you just told me, K values well above the normal limits, right? Coupled with thinning of the cornea, which is 401, 410, coupled with this other bad scan, which is showing, this is basically, bad scan, this is basically comparison to the normal population, and you are getting all these parameters outside the normal range along with this and this scenario. So you should be able to see confidently that this is the case of keratoconus. If you start saying it can be, then a perfectly well replied answer, you can cause problems for yourself. Okay, so this is the case of keratoconus. Okay, so now my question is, this patient, this boy has come to you. This is a pentacam now. What next? What will you advise to this patient?
Okay, first of all, I should examine the other eye. I should counsel for examining his
Let's say that also
family
has a
member.
similar scenario, almost similar.
Okay.
Pentacam. Now, what will you do? What is the treatment?
Okay, the treatment is multifactorial. Since this patient sees his visual acuity is 6669, I can recommend to do corneal cross-linking and close follow-up. If the visual acuity is
So will you
less,
do follow-up, or will you recommend CXL cross-linkage right away?
sorry?
Would you like to wait for some time before you do corneal cross-linkage, or will you advise that you should go for CXL?
يعني to my mind and at my institution we should interfere rapidly because this is a young patient and his pentacam is not good at all.
Very good. You should be very clear. Now this person has keratoconus, young patient, you will go for CXL. Good. So now we come to the CXL. One, you said since patient is good, he can continue using glasses. Or what are the other options for correction? If comfortable with glasses, he will continue with the glasses, or we can do some other options. So now this patient, now again, keep in mind this scan. When doing CXL, is there some special thing you will do to do CXL? How will you plan CXL? What will you do? What kind of solution? What I'm asking is,
we have
any precautions you want to take? Will you do it with epi on or off? What kind of solution you will use? This is my question.
I think we have a sufficient corneal thickness so we can do it epi off as it is more effective.
Corneal thickness is 401 minimum, right?
Yeah.
401 is the thinnest corneal thickness. So what happens if the cornea is, so basically so okay, let me ask you a question and you will automatically reply this. In basically CXL, what we do, we infuse the cornea with what? Basically, we are doing it
with riboflavin and assisted with ultraviolet radiations.
Yes. So is there any rationale behind using riboflavin rather than other things? Are there any contraindications to corneal cross-linkage? Like you can't do corneal cross-linkage on every case. Are there any contraindications relative?
Yes, if there is a cornea thinner than 400, if there is allergy to riboflavin,
cornea is thinner than 400, then
yes,
it becomes difficult. So in this case, corneal thickness is nearing 400, 401. So now tell me, what will you do? What precautions you will take? Can you do anything? Can you alter the formulation of riboflavin?
Assisted contact lens riboflavin.
One. Any other? Good. That is one option.
Epi-on?
Or epi-on. Okay. Epi-on. Because if you take off epithelium, then it will penetrate deep into the cornea. That will become contraindication. Number 2. Number 3, another very important, which is usually done, formulation of riboflavin. You can use hypoosmolar riboflavin, right?
Okay.
What will hypoosmolar, how will hypoosmolar riboflavin help in this case?
It will stick in the cornea. It will
yes, it will thicken up the cornea, right? So what happens? So just to clarify one more point in this case, what happens if you take off, like you initially said, epi off and normal? What can happen to this eye if we use that technique? What problem can we have?
Maybe corneal perforation, or I can increase the corneal ectasia.
No, it can cause endothelial damage, right?
Oh.
Basically, perforation never happens. Basically, if
Okay.
you are, our concern is that we are using riboflavin, which is a photosensitizer. It should stay in the stroma. That is the reason very thin corneas, they become relative contraindication. And then we use UVAs. Riboflavin has excitation peak which matches UVA rays. So hence you use that. So if you are doing it on thin cornea, that will cause corneal damage, endothelial damage. So we don't want that. Hence we use hyposmolar. It thickens the cornea and it improves. Okay. So I think I have. So any contraindication before you go for CXL in this young boy? Any conditions you want to rule out? One you said that is on Pentagam you're seeing. Any other thing you want to find out in history to see if there is any kind of contraindication? Two more things.
Actually,
previous
I
herpetic infection.
Mm-hmm.
If there is previous herpetic infection, history of severe dry eyes, all these problems, or persistent epithelial defects, poor healing, all these things you have to rule out. Okay?
Okay. Can I ask a question, please?
Yes, yes.
Sometimes in resistant herpetic infection, we can treat it with cross-linking, isn't it?
In not herpetic infections.
Okay.
If there are bacterial keratitis, then we can use cross-linkage, because these rays, they basically kill the germs, but not herpetic. Herpetic infections are contraindication, not bacterial keratitis.
Okay, thank you.
Okay. This is question number 2. Okay, so who will take this question?
Yes, sir, I can take it.
Okay, Dr. Zahran. Okay, Dr. Zahran, look at this picture and give your diagnosis.
It's a tear segment color photo of the right eye showing limbal swelling encroaching on the cornea. Most probably it's limbal dermoid.
So what is your diagnosis?
Limbal dermoid.
Limbal dermoid. Okay, so this patient comes to you. First tell me what kind of lesion is this limbal dermoid? Any specific term for that? Coriostoma.
Coriostoma.
Okay, so this patient comes to you. Tell me how would you like to do some, this patient wants some treatment because patient doesn't like seeing this lesion on his eye. So is there any investigation? What treatment will you do? What investigation you would like to do?
Okay, at first I will investigate the patient systemically because it may be associated with golden heart syndrome or any other syndrome. Second thing, I will do UBM and the anterior segment OCT to detect the line of demarcation under the limbal dermoid and if there is any infiltration to the angle. The third thing is that I will examine the ocular eye as routine examination, anterior segment examination, and visual active reaction fundus examination. If this is swelling causing astigmatism or it's obscuring the visual axis of the patient, then I will consider to do surgery.
So okay, hold on. So first tell me, when you do OCT, what is it you're looking for on OCT of this lesion?
Line of demarcation between this.
So can you grade this lesion based on OCT?
No, I can't.
Can you? There is a grading system. I will tell you in a short while. First, tell me, okay, so you told me that you will like to see some systemic affiliations, right? Associations? Is that so?
Yes.
Are there any ocular associations with this limbal dermoid, or is it an isolated entity? What do you say?
Duane syndrome? Duane?
Yes, yes. What else? There can be,
Uh,
start from the out, corneal or scleral staphylomas, right? Then there can be aniridia. It can have aphakia or cataract. There can be microphthalmos. There can be lacrimal gland stenosis. And Duane syndrome, yes, very important. Sometimes there can be neurofibroma and some other conditions. Okay, so now my question is, you said you don't know this. That is the basic question. That was basically question. So how will you remove this? So how will you plan? Okay, so my question is, you did OCT, and what are the indications for the treatment? First, tell me. This patient doesn't like any other indications based on which you will say that we want to take it off?
If it's causing astigmatism or cosmetic disfigurement or obscuring the visual access of the patient.
Yes. So looking at this picture, how will you plan the treatment? What will you do?
I think I can do superficial lamellar keratectomy or phototherapeutic keratectomy or surgical excisional biopsy.
You'll do biopsy?
No, surgical excision.
Surgical excision. So what kind of surgical excision you will do? You will just scrape it off, or will you do something without knowing the depths? How will you decide what things you need during the treatment?
Superficial lamellar keratectomy.
Okay, Dr. Zahran. Okay, let me. Anyone else who knows the grading of this limbal dermoid, or should I tell you? Because this question is important.
Please tell.
Okay. Basically, if there is a limbal dermoid, we have to grade it according to OCT. Okay. So the grading system is based on the size and its encroachment onto the cornea. So grade 1 are if they are less than 5 millimeter and they are confined to the limbus. That is grade 1. Okay. So these are superficial and just in this case, again, in grade 1, when you look at OCT, you can further define how deep it is. If it is just superficial, less than 50 microns, you can simply scrape it off, like just remove it without using anything. And if it is deeper, like it's reaching 100 micron, then it will be a large defect. You will have to remove it, and then you have to put some amniotic membrane graft and limbal stem cell graft on that. Okay, so grade 1 is small limbal dermoid, less than 5 millimeters, and it is confined to the limbus, and then according to the depth. Then comes grade 2. Grade 2 is involving the cornea, most of the cornea, and it reaches desmoid membrane but doesn't really involve it. So it means it's not reaching into the anterior chamber. In that case, if you want to remove it, that will be the scenario where vision will be affected and all these problems. When you want to remove that, you will have to do lots of things. You will remove that. You will have to use amniotic membrane graft, sometimes pericardial graft as well, and limbal stem cell graft. I mean, you have to restore all the tissue you have lost, and as well as the limbal stem cells which are lost. And then comes a grade 3, which involves whole of the cornea. It's involving the desmoid membrane and reaching into the anterior chamber. In that case, the solution is full-fledged surgical reconstruction. Okay. So this question, I have added this. When you see this presentation on, I will send it in my group as well, but this is very important. You must memorize all that, because if this is one question, you cannot randomly scrape it off. It has to be based on the OCT. Okay? Okay, Dr. Zahran?
Okay, ma'am.
So we move to the next question. Anyone can volunteer? Anyone?
Sir, madam, I can volunteer.
Okay. Dr. Rajna. Okay. So a 58 years old diabetic man with good glycemic control comes to you with the wish that he wants to remove glasses. Okay. He has posterior subcapsular cataract grade 1 and he refuses monofocal vision. What is your advice to this patient? And what can you do for him?
Yeah, since he's having diabetes and some cataract, I can mm, I can tell him about the options of multifocal lens, but
Yes.
there is a risk. There is a risk of further development of diabetic retinopathy, diabetic macular edema, and then complicate his vision. So I have to communicate him with this all aspect. So
Yes.
if he's, I will counsel him. You can go for this monofocal lens and then use spectacle. If he is not willing, I can then talk about him about the uh, options of lenses.
So patient is hell-bent. He wants to have multifocal IOLs, and you have checked everything. He didn't have any kind of like retinopathy before. Now the patient wants further information. What kind of multifocal IOLs are available? Can you tell?
So, madam, there are two type like refractive and diffractive type of IOLs are available. The refractive type, there will be the multiple ring.
There are in fact 4 types, Dr. Najla. Refractive, diffractive, another is extended depth of focus, EDOF.
Yeah.
Okay. And then
Yes.
there is new kind that is accommodative. These are new generations.
Yes.
Accommodative, they have the ability to slightly like undergo accommodation, and they are the new kind of a multifocal IOL. Okay, good. So in addition to this, so now you have told the patient about different multifocal IOLs. Any contraindications before? Now you are going to assess the patient for multifocal from that viewpoint. Okay. Before you prescribe, would you like to do some investigations? Or are there any contraindications you're looking for?
Yeah, there is
And the
a
patient is
if there is
diabetic?
corneal scar, corneal abnormality, previous corneal procedures like presbyopia, LASIK. This kind of patient will have severe glare post surgery.
Okay.
So
What else you would like to see? No, he didn't have any kind of problem. But otherwise, a normal patient, what are the things you will notice in the lens other than cornea? Patient is diabetic. Diabetic have what kind of people usually?
diabetic retinopathy is an absolute contraindication for
Yes.
multifocal IOL.
Okay. 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 So okay, so what investigations you would do before you can advise and why?
And do biometry and corneal thickness and specular microscopy. All these things we can do, and we have to know.
Biometry, Dr. Rachra, you have to do in any case. Any special investigation you want to do for multifocal IOL, keep in mind their function. You yourself said they have multiple like rings, okay, on the cornea. So what can you think? What kind of what investigation you would like to do?
What can you do to check there is oil centration or it is oil center related? So what specific test will you do or what specific angle will you focus on?
Okay. Okay. So, Dr. Najla, what investigation?
Yeah. I'm not sure.
Pentacam.
Yeah. Okay. Pentacam.
What will you see in the pentacam? Can you think of anything? Basically, what are you looking for?
In the pentacam, the astigmatism, the pre-op astigmatism and the corneal ectatic disorders like keratoconus, stereo margin degeneration, pellucid margin degeneration, this kind of.
Basically, you're correct. You're correct. You're basically looking for posterior wall elevations, right?
Okay.
Any significant astigmatism that will be visible even here on auto-ref and everything. But the posterior corneal wall elevations, and that basically if the D values that is beyond 1.16, that will cause intractable glare and all these things. So pentacam is very important. You cannot proceed without pentacam for multifocal IOL. Other thing you can do is abrometry and OCT. Obviously, you have mentioned multiple times that you can go for that. Okay, so what are operative precautions you need to take to achieve good result from multifocal IOL? Anything special you want to make sure in surgical points?
Yeah, make good central capsular axis.
Before that, very good corneal incision so that you do not induce any kind of astigmatism. Good.
Very good corneal
Refractive.
incision, and in the and very good posterior capsule polishing also. Otherwise, patient might have this posterior capsular opacity.
Okay. What else? Proper centration after
Yeah.
IOL.
Yes.
And make sure you don't touch the iris. The question I was asking you before in examination is if there are myotic pupils. Most diabetics have myotic pupils. Okay. So if pupillary abnormalities are present, too wide or too myotic, this can cause problems in multifocal IOLs. Okay, so you will make sure that there is no zonular dehiscence. You have to be gentle, so IOL has to be centered. Okay, so next question, because we have lots of questions. And okay, so operative precaution.
Can I ask one
Yes.
question?
Yes.
I mean, does we have to check angle kappa also if we are planning for multifocal?
You have to, because if you are making a central rexis and angle cap and patient is looking from elsewhere, this will cause intractable problems. So that's why we use abrometry as well. So this is very important. Multifocal IOL is not like monofocal. You have to be very careful about that. And despite doing everything absolutely fine, patient can have lots of problems, glare and all these things. So yes, angle kappa, very important. So during surgery, zonular dehiscence, you have to make sure you have to be very gentle and you have to take out all viscoelastic, etc. Okay, so next question. 4 months after the surgery, and patient is still dissatisfied with the results. What can be the reason and what will be your advice to this patient?
Yeah, main reason is glare, halos, then reduced contrast sensitivity.
So will it settle down? Your question's answer is your patient is asking you, will it settle down or you have to do
reduced
something?
Contrast sensitivity will not settle down. It will be there. Yeah, but glare or halo, the patient may adjust with that.
Which is called neuroadaptability, right?
Neuroadaptability, yes.
That is very important. So go back when you are counseling the patient about multifocal IOL, you have to tell the patient, in addition to diabetic retinopathy, that there is a thing called neuroadaptability, which will take some time. So if you operate on one eye with multifocal IOL and leave the other eye, the patient will be like, no matter what you do, patient won't be comfortable. Okay, so what other things? Glare and halos, what else can happen? Think out of box. There can be
astigmatism.
From where will be that astigmatism arising?
From the corneal incision, the residual astigmatism from the corneal incision.
Or if you have missed on pentacam, if you do not do pentacam before that, if you miss that, then there can be astigmatism, right? It is arising from the posterior wall and it's causing problem. What else? There can be PC thickness.
IOL may be decenter.
Yes, it can be decentered, or there can be pupillary abnormalities, or just like Dr. Rishi mentioned, angle kappa, you have missed that. Or there can be PC thickening, important. Sometimes if you haven't like polished it, PC thickening. What else? Dry eyes.
Dry eye, maculopathy. Since it's a diabetic patient.
And ametropia. There is some difference which we have already mentioned. Astigmatism more than 0.75 will definitely bother them. Okay. So, okay. So this question, I have 14 questions. When you get tired, you can let me know. We can stop. So otherwise, I will continue till you are really studying. So who else? Who wants to take this question? Anyone else?
Yeah, hi ma'am, I can take this.
Okay, ma'am, I'll
Okay.
Anirban.
Yeah. Yes, ma'am.
Okay, take this question. Okay, a non-patient of keratoconus develops corneal hydrops. Okay, and is being treated with medical treatment, but there is no significant improvement. First revise, uh, what is the medical treatment that is needed to treat the corneal hydrops?
If the patient develops corneal hydrops, we'll treat with hypertonic saline and lubricants, then cycloplegics to prevent pain, and steroids to
Antibiotic.
decrease antibiotics and steroids to decrease inflammation.
Okay, perfect. Okay, so this patient comes to you that despite all this medical treatment, patient is not, there is no significant improvement. Okay, now how will you assess this patient and what will you do?
If after medical management also, if patient is not improving, then we can investigate. We can do an anterior-segment OCT, and then we can give intracameral gas to.
On OCT, you said
Okay.
you will do OCT. Very good, very good. So basically, what are you going to do? What are you trying to see on OCT, which will modify your treatment?
I think whether there are any clefts or not, intrastromal clefts or those kind of things.
You want to see the size of defect,
The
how much
size
break,
of defects, exactly.
because like this, you can see everything clearly. Okay, so based on that, you will modify your treatment. So what will be your next treatment? First tell non-invasive or like minimally invasive, and then enumerate that.
So first, I think we can go for that intracameral gas, like SF6, isovolumetric SF6 or C3F8, or if that is not working, then we can try compression sutures.
Before that, compression sutures, can you do anything?
Um,
Intracameral gas is one option. Anything
okay.
else?
No, ma'am, I don't know.
Intracameral plasma.
Okay.
Right?
Okay.
How will intracameral plasma help, like, improve this corneal hydrops?
I think the growth factors in the plasma may help in healing of the descemet membrane.
Endothelium.
Endothelium,
right?
okay.
0.3 ml of plasma you inject. Okay, so you have done all these, do these things, and it's not improving. Then what other options you can have?
In after these also, if it's not improving, then we might have to go for keratoplasty, like we can
You
before.
you can do compression suture one.
Yeah, after compression. Okay, after compression sutures, even if it's not improving, then the
There is
last option.
another option. There is thermokeratoplasty, like you slightly
Okay.
burn that area, which also helps to improve, reduce edema.
Okay.
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 Then full keratoplasty. Then you can go for
penetrating.
before penetrating the keratoplasty. There are some other keratoplasties you can do,
I
right?
think, ma'am, in some studies they've showed that you can do a DSEC also to replace the endothelium and descemet membrane.
Yes.
That can be helpful.
You should do that. Basically, look. So purpose of this is that whenever there is a case of acute corneal hydrops, you give full treatment. If patient comes with not improvement, you review the treatment. Patient may not be using the right medicine. There may be like missing few things, hyperosmolar agent or anti-glaucoma. Sometimes you can put bandage contact lens. You review the treatment.
Right.
And you couple with that, and then you investigate it like properly. But the purpose of OCT is you want to see, sometimes you have to go for compression sutures directly. Like if there is a large defect, descemet membrane is hanging into the anterior chamber, you can try to give gases, but sometimes you have to go directly for this compression sutures, right? So if it is intact, but you're seeing it's not hanging into the anterior chamber, then you can do all these things. I said you can use gases. Plasma is very important. You must mention that. Then you can try thermokeratoplasty. If all these things fail, then you can go for the next step. Keratoplasty, these DMEK, you just change. You are changing the endothelium. You're changing the pathology, basically replacing the pathology. And if this fails, it's a gone case, and totally you're developing all these kind of opacity, then you can go for penetrating keratoplasty. That will come in the end. Okay, so
Yes, ma'am.
you must memorize all the. But important is the role of gases and plasma,
Plasma.
plus role of OCT. Don't say anything like without that. I have one more question, which was missed even last time. Is there any role of confocal microscopy in the treatment of acute corneal hydrops, do you think, in assessing prognosis?
I don't know, ma'am. I don't know.
Usually, we don't usually use these things, but sometimes when you're treating a case of corneal hydrops, you have to look at two things. One, you have to preempt long-term complications as well in addition to the treatment. So are some studies that show that if you do confocal microscopy and you find some unusual stromal cells with speckled cell bodies, that shows that this cornea will develop new vascularizations. So just for exam point of view, you should know that.
Okay.
And in addition to that, you must know the grading system. You have to, if you tell that I will grade, document the corneal edema in a proper way to monitor the progress coupled with OCT, that will help you to formulate your treatment properly. Okay.
So what is the grading, ma'am?
To grade the corneal edema.
Oh, okay.
Like you grade corneal edema, that conventional method which we use after post-op. So
Right.
if you say say that I will start grading the corneal edema to monitor the prognosis,
Right.
that will be very good a clinical approach. Okay. Okay. So
Madam,
next
what
question.
was Madam, I have a question. What was this role of confocal microscopy?
Confocal microscopy is just to see the prognosis of the given cornea. In confocal microscopy, if you see abnormal cells with speckled bodies, like there are dots on the bodies, abnormal cell bodies, that shows that this cornea will develop new vascularization. Poor prognosis.
Oh, okay, madam.
Okay.
Ma'am, is these abnormal cells are the one that means guttate, because this is what we see in specular? I mean, guttate, the endothelium cells, you mean?
Stromal cells. They are becoming abnormal. They are developing abnormal pigmentation dots type things.
So what will we will see the finding in the stroma, because of what I mean the cells means we will see some A's or some, like how we will see that this is abnormal cells, because stroma looks amorphous.
On confocal microscopy, you can see you can see the endothelial cells. Sorry, I think these are the epithelial. All those cells. Actually, I saw this picture. All those cells, they will be different from normal. They will have speckled bodies. They just show that this cornea has poor prognosis. It's just from okay. So you can
it is in the
just keep it in
endothelium.
mind. If some examiner becomes stuck on that, like me, then you can remember that this was told to you. Okay, don't worry too much about that. So now this is the next question. Okay, this is very important question. Anyone can take this question.
Okay, I can take it.
Dr. Amar. Okay, Dr. Amar, a 48 years old woman underwent an uneventful cataract surgery, but ends up having a post-operative astigmatism of -2.50 at 165 degrees. Okay. Her previous record shows almost insignificant astigmatism. What do you think can be the cause of this newly developed astigmatism in a post-op case?
Okay, the cause of this newly developed astigmatism can be first, maybe it was a corneal astigmatism. There was a corneal astigmatism, but was compensated with lenticular. So after removal of the lens, the corneal astigmatism appeared.
Yes, very good. What else?
Okay, second, maybe incisional surgical incision induced.
Good.
Third, maybe
Amar, what kind of corneal incision develops astigmatism, and what kind of incision we should give to avoid this astigmatism?
I think more anterior incision, like corneal incision, can induce astigmatism. especially if the plane of the incision is with the same plane as the flat meridian, so can induce more what else? Okay, maybe
size of incision.
Size of the incision, yes.
If it is 2.2 or less, it won't cause much astigmatism. But if it is more than 2.2, then what other causes? Yes, very good start.
Other causes can be desmet folds or desmet membrane detachment.
Yes.
During the surgery. Maybe tilted or decentered IOL inside the bag.
Yes. Or
what else?
Zonular. Sometimes, or position of the lens. If you change the position of the lens, you are unable to put the IOL direct into the bag. It's half in the bag, half
another cause.
Tilted.
Yes.
Okay.
Another cause may be suture induced if I did close the wound with a suture.
Tight suture.
Tight
so
suture,
basically,
yes.
we can divide it into corneal causes or IOL related causes, right? So you have mentioned almost all of them. Okay, so what is the management? Assuming there is IOL is centered perfectly, there is no problem in the IOL. This is just corneal astigmatism. Before that, we may have missed some posterior wall elevations. As you said, that they may have been compensated by cataract. Once we remove that, all those manifest. So one source of origin can be corneal astigmatism arising from the back wall elevations. So we have to keep in mind that. So assuming there is no IOL related problem, this is just corneal astigmatism, this 2.50, 165 degrees, what will be the treatment? Step by step.
Okay, okay, the treatment can be, we can think of IOL replacement with a toric IOL to correct this astigmatism.
Before that,
we can first correct with a spectacle. Second,
we can remove the tight suture.
We can remove the tight suture.
Or
we can do limbal releasing incision in the
relaxing incisions.
Limbal relaxing incision, yes.
Limbal relaxing, remember, one relaxing incision that will correct how much astigmatism? About 0.5 to 0.65. So you can even give two relaxing incision in the steep meridian, like you assess where is the astigmatism, and you can give two relaxing incision in the same meridian at the opposite ends. Okay, so removal of suture, relaxing incisions. What else?
Can be laser corrected.
That is much. You have done everything remaining. You can do with excimer laser instead of going inside the eye, taking out the lens, putting in the toric IOL. So simpler ways you can do excimer laser and you can correct that. Good, very good. Okay, so next question. Okay, anyone can take it. Who wants to take this question? It's very easy question. Anyone can take, don't worry, we will quickly finish it so that you go through all the important topics, okay?
Okay, Dr. Samina, I'll take it.
Okay, okay, so a 26 years old man developed corneal ulcer, bacterial keratitis, about 6 months ago, okay? And he was treated with topical antibiotics. Now here it comes to you that his vision has deteriorated. After this whole episode, his vision has reduced. He was EBITRO before that. When you check that, his best corrected visual acuity is plus 1.50 with minus 2 cylinder at 85 degrees, and best corrected vision is 618. You can see the picture. Tell me what can be the cause of, what is the reason for this astigmatism, and what can you do for that patient?
I can see an anterior segment photo for, and there is mid opacity in the cornea. It is encroaching the visual axis.
So
So
what
there
do you
is
think?
So I think there is this stromal scarring.
So what is your treatment? Patient wants some treatment for this.
But first, I'll do anterior segment OCT to assess the depth of this scar. It is post-infectious.
So what did you say? What will you do?
I'll do anterior segment OCT to assess the depth of this
Okay.
of the.
Okay. So what do you want to see on OCT? The depth of opacity?
Yes, the depth of this
So
opacity.
why are you doing that? Why are we doing OCT and assessing the depth of opacity? What are you planning?
So I can treat the patient with phototherapeutic keratectomy.
PTK.
Yes.
Okay. So what are the criteria on OCT? Or you can say, how will you decide that this person is the right candidate for PTK, phototherapeutic keratectomy? Is there some criteria on OCT?
Yes. If this opacity doesn't invade more than 20% of in the depth of the stroma.
More than? It shouldn't be?
It shouldn't be. It should be less than 20% in depth.
Okay, anterior 1/3. It should involve anterior 1/3. And what else? What other things you can consider? How much stroma should be left after you have removed this opacity? It shouldn't be less than 250 microns. 250 is too thin. I think 300, but still books say 250 microns. So you need to do CCT as well, right? So you're noticing that as well. So you're planning PTK. First tell me, it's been just 6 months when he had this bacterial keratitis. Would you like to wait for some time or would you go for PTK straight away?
Wait for some time. I saw.
Sometimes these opacities do recover with the use of topical steroids, right? So we can wait for some time to get it stabilized and then we can plan for PTK. So any contraindications for PTK you would like to ask this patient? You want to rule out which you don't want to do?
Poor healing, poor healing.
What
poor
can
healing,
be the condition?
or if it is
okay, but what can be the condition in a young man
disease,
which can lead to poor healing?
Autoimmune disease, or collagen disease.
Yes, yes.
Dry eye, ocular surface disease, or dry eye.
And type 1 diabetes as well, right?
Yes, type 1 diabetes. Yeah.
Okay, so what are the limitations of PTK? You have to tell something to this patient. But he is expecting that after PTK, he will be absolutely fine, right? So what are the limitations of PTK and what would you like to tell this patient?
I tell the patient that post-op there will be a pain and heaviness and his vision will not recur immediately after the operation. And he will take medications for time, steroids and anti-inflammatory and lubricants. And he may suffer from dryness for a while. Also.
Dry eyes. What else? Sometimes patients expect that they are getting this laser done and they will be rid of glasses. Would you like to tell something? Will there be anything you would like to do again, or like what kind of refractive error? We may be able to remove astigmatism, but there will be some induced hypermetropia.
Hypermetropic shifting.
And we may need to do another procedure later on once it stabilizes. Based on pentacam, we may need to do some correction later on. Okay?
Okay.
Good. Okay, so we have...
Can I ask a question, please?
Yes.
What is the cause of this hypermetropic shift? Is it the PTK or the opacity?
What is the cause of the astigmatism? You're asking this? What is the cause?
Yeah, of hypermetropic shift after PTK.
Basically, when we, so repeat your question again, please.
What is the cause of hypermetropic shift after phototherapeutic keratoconus?
Because we are removing the stroma from the center. PTK basically uses excimer laser. Excimer laser is the same laser which is used for all these PRK and that. Okay, so any kind of shift depends on from where you are removing the stroma. So when you are removing the stroma from the middle, like in the center, you are basically making it flat. Is it so? So when we are treating myopia, we want to make the eye slightly flatter from the center. Yeah, basically we are giving it hypermetropic shift. So now this opacity is right in the center. Are you getting me? This opacity is right in the middle. Then you will flatten it up further. There will be hypermetropia because you are flattening it up. You are creating basically, you are making eye flatter from the middle so that there will be positive shift. That's why I said that in this case scenario, PTK may not be the solution. You wait for some time with the passage of time, this positive shift that reverts back. Like you give steroids carefully. Steroids usually give plus shift because they are basically improving the layout of collagen. So you wait for some time, give it stabilize so that it reaches some stage where it is not improving anymore. Then you try to remove this minus cylinder. Like PTK works in different ways. It sometimes removes the irregularities and just removes the cylinder. And but in doing that, you're actually removing the stroma, so it gives hyperopic shift. It is not that pronounced that is achieved in other PRK. Like in PRK, if you remove 12 micron, there will be +1 diopter shift. But in PTK, this hypermetropic shift is very slight. Like you remove 30 to 40 mics to 30 to 35 microns, and it will be just 0.75. But it will be worth it because at least the cornea will be clear. You will be able to see. Okay.
Thank you.
So when we will treat hypermetropia, what we'll do, we will basically treat the cornea from the periphery. We will make it slightly concave. So we can correct that.
Ma'am, we can correct the full refractive error with the PTK also.
We can aim that. You do pentacam, you aim that you can do that, but still there will be some residual refractive error, and you can later on correct that. Like you have to prepare the patient that it may not be absolutely correct, so we may have to do it again. Now this question is very important because I will show you a few OCTs here, and I would like all of you to focus because I have like noticed that many times you have lots of problem in reading the OCT. So first read this question. Anyone can take this question, and then I will like.
Okay, ma'am, I'll take.
So you notice this conjunctival lesion in the routine examination of a patient. Patient doesn't have really any problem. He just says that he has mild itching and there is some this membrane type thing on his eye. First, based on this clinical picture, what are the things? What can be the cause of this kind of lesion in a patient? Give your differential. You can describe if you want, and tell me.
Yeah, so this is a diffuse slit lamp picture, diffuse illumination picture of the slit lamp showing the right eye in which the patient is looking up. There is a fleshy red mass extending from the inferior fornix till the limbus. And there are some blood vessels over it, can be some feeder vessels over it, and there is no discharge seen. Yeah, and the size I can tell that it is from in the limbus it is from 5 to till from 4 till 6 o'clock, and it is broad based, extending.
So what is your differential? Very good.
So
very
my
good.
first differential diagnosis is OSSN, ocular surface neoplasia. Ocular surface
what makes
squamous
you
neoplasia.
say? What makes you very good? Very good. By the way, what makes you say OSSN at the top? Give the key features based on which you have put this on the top of your list.
First of all, this is that the patient doesn't have any symptoms apart with it is symptomless, and it is like the feeding vessels are there, and there is the surface. The surface is
Gelatinous, unusual
yeah,
appearance, gelatinous
yeah,
appearance. Its
gelatinous
location
and
is slightly unusual. Like this could be pterygium, but that is on the nasal side.
yeah,
So yes. So what else you would
unusual
like to consider?
appearance.
What other things you would like to
Then
consider?
I can say one another differential diagnosis as pterygium, but its location does not suit it. The second thing which I can say
But
is
it can
pseudopterygium,
be
which can be
pseudopterygium. Can it be
pseudopterygium. It can be
pseudopterygium because
pseudopterygium because
previous chemical burns or whatever, right?
yes, if he
Unlikely,
is
but it
having
can
any
be.
history of yes,
What
it can be
what else?
pseudopterygium.
What else?
It can be membranous conjunctivitis.
Yes. Yeah. And anything infiltrating the conjunctiva, you want to rule out other lesions like it can be lymphoma, lymphoid hyperplasia, it can be amyloidosis, okay, and it can be pterygium. So we have to rule out all these. So what investigation now? How will you investigate that?
So in this, we should go for excisional biopsy.
That is the gold standard.
Fully removed.
Perfect.
Gold standard.
But can you do anything before that? Like you are in your clinic and you have all the facilities. Is there any other tool which you can give you a very good idea what you're dealing with, so that you can plan if you want to plan excision?
We can do the blotting cytology. I mean, we can take the cells through the what is that called? This is, I think there's some name for it. I forgot the name. I think impression cytology.
Impression cytology. Impression cytology.
Impression cytology. So we take the cells and then we can examine that one. We can do, and also if we want to see the depth. Depth of this, we can do OCT, anterior segment OCT.
OCT is a very good tool. Okay, so I'm going to show you OCT.
Yeah.
And tell me, what do you think? First, tell me, where is the level of lesion?
Okay, so
look, always when you're reading OCT, just for other people, whenever you're reading OCT, always remember, keep this thing in mind, and differential you've just mentioned in mind. Okay, that will make things easier for you. So all these 4 or 5 things you have told me, it is one of those. So this lesion, one, you can see it's superficial, right?
Yeah.
So what do you see?
I can see the limbus.
Okay. Okay. Look, Dr. Rashi, this is, isn't it the lesion, outermost lesion? Is it epithelial or subepithelial? Tell me.
This lesion is so it is over the epithelium, but
it is epithelial. It is epithelial, right? You can't see anything about that. I'm just giving you people slight cheat course so that in exam you don't think too much about that. You are expecting it can be OSSN or lymphoma, lymphoid hyperplasia or pterygium, right? OSSN is epithelial. In pterygium, pterygium is subepithelial fibrotic band. I may have added a slide of that. Lymphoma and lymphoid hyperplasia, they are subepithelial lesions. Okay, so normally look, this is the outermost lesion, outermost layer, this one. Okay, this is coming here and this is continuing and this is becoming like thickened up. Okay, so this is epithelial lesion. So the topmost line, nothing. If you can see some band, or I'll show you, then it is subepithelial, then you can go in other direction. So based on this, if this is the OCT, your diagnosis is, this is OSSN, right?
Yes.
Okay, epithelial. Now, what were your other diagnoses? Lymphoma, Now remember, I
Okay, this is
told you.
lymphoma, subepithelial.
Uh-huh,
Yes.
okay. Please remember, everyone, and if you have any question, do ask, because OCT, even it bothers me. I keep looking again and again. Outermost layer, and look, this outermost layer is becoming, actually, this one is becoming thickened up. Okay, and all the layers are under that. If it is at the top, dome-shaped lesion, outermost, this is epithelial lesion, and keep it in mind what you said before, that I'm expecting OSSN, all these things. So this is now next lesion. This is subepithelial. Why am I saying? Look at this. Trace this part. This is epithelium. This is continuing. You can see a white black line in between, right?
Yeah.
So this is epithelium, and this lesion is subepithelial. So subepithelial, your diagnosis becomes, it can be either lymphoma, lymphoid hyperplasia, or it can be amyloidosis, right?
Yeah.
So this is typical picture of lymphoma. How is it different from OSSN? OSSN is outermost layer. In first glance, they look same, but if you look carefully, you should be able to. And here, this is encapsulated, like clear, well-defined lesion under the epithelium. This is lymphoma, right? Now I'm going to the next. This is lymphoid hyperplasia. Like, this is another variant of benign lymphoid hyperplasia. Why am I saying that? Again, you can see this. Here is epithelium. There is the black band, you can see. So whatever it is under the epithelium. So it can be either, it can be either amyloidosis or lymphoid hyperplasia. You can just give differential. You can't be sure till you do the culture sensitivity or whatever, like cytology. Without that, you can't say. So this is more like, this is more like amyloidosis. Okay. So this is OSSN.
Yeah.
This is lymphoma because it's subepithelial. And this is more like amyloidosis, irregular sort of thing. Okay.
Okay.
So what is the treatment for this patient?
So excisional biopsy, after doing OCT, we can go for the excisional biopsy with the graft, with autograft or amniotic membrane transplant.
Basically, you want to excise that surgical excision, right?
Surgical excision, yes.
With 4 millimeter margin on all sides to remove it fully, right? Is that what's it?
The
patient doesn't agree to your treatment. Patient is living with this. Any other thing you can give?
Yes, mitomycin we can give.
Either topical form or injections. 5F.
Mitomycin drops. We can make drops also.
Yes, you can do that. But the accurate treatment is removal. Any question? Anyone has any question regarding OCT?
Yes, again, regarding the pterygium, how it appears.
Pterygium, look, pterygium, you will have a normal epithelium, like, let me forget this part. You will find a fibrotic band creeping under that. Like, there will be normal structure of the OCT. Just a band, fibrotic band creeping under the epithelium. Because that is what pathology is actually. Basically, whatever pathology you are thinking, you are actually seeing it with your eyes on OCT. I'll show you the picture. I'll send the picture of that OCT as well, of the pterygium. I forgot to add that. But remember one thing, you have to first, don't forget. So cheat code is that always remember what DD you gave. So clinical suspicion, location, you remember it's a conjunctival lesion. Don't think about corneal lesions. Then remember what differential you have given in mind, and then start seeing. First, identify where is the lesion. It is epithelial, think about epithelial wall. If it's subepithelial, think about cyst, lymphoma, or all these things. Okay?
Yeah.
Okay, so next question. Okay, we have just few more questions. Okay, we'll do it quickly so that you go through all these tricky things. Anyone can take this question.
Yes, madam, I think.
So a patient with -15 diopters of myopia wants to get excimer laser done. Let's say 25 years old woman. Her CCT is 489 and 501. microns, right and left. What is your opinion about it? What do you think? Can she have excimer laser?
Okay, first of all, I should inquire about the two important things. Number one, the age of this patient. Okay. Number two, the stability of her refraction, her or his her refraction. Okay. If she is above 21 years and her refraction is stable for more than 1 year, I should counsel her for that laser. Excimer laser is not suitable for her as she has a high error and also very low, more or less a low central corneal thickness. So she is not a candidate for excimer laser at all. Okay, I should counsel her to continue to wear her spectacles or contact lens. I should also I can recommend her an intraocular lens or intraocular contact lens. Okay, I should.
Correct.
But I should also search for hair astigmatism so I can adjust the ICL to be also with the toric type. I should do investigations pentacam white to white her actual reflection. I should examine her fundus thoroughly to exclude any chorioretinal generations, any peripheral degenerations that can progress to retinal detachment.
So basically, you have advised what procedure you have advised to this patient?
I'm advising ICL.
Okay, good. Okay, so you said you will do pentacam. Very good. What other things you want to do? What are the what is the significance of doing all these things? Measuring the doing OCT of anterior chamber. Why are we going through OCT and all these things? Phakic IOLs. What is the significance of that?
To measure the anterior chamber depth, white to white.
White. Why is that important? Because phakic IOLs, these IOLs, they're quite large in size, right? You are putting them into over a natural lens, right?
Yes.
So you have to, the size is from 250 to 750 microns, the phakic IOL. If you do not measure white to white and for that matter, anterior chamber depth as well, what is the cutoff limit of anterior chamber depth for these kind of IOLs? AC depth?
Not less than 2.5 milli.
2.8 millimeters. This is important because if it is less than that and you try to put that IOL into that, what will it do? It will cause corneal decompensation.
Yeah.
It will block the angle. So it's very important. Again, these IOLs are not like simple monofocal IOLs. So white to white, very good. AC depth, but you should know the reasoning behind that because you are trying to choose the right side of that. Perfect. And what else? Endothelial cell count is very important. How much should be minimum endothelial cell count?
This is according to the age of the patient, but I think it's not less than
Let's say this patient is more than 45. No, so this is young patient.
Not less than 1,000.
Okay. Perfect. So what happens? So
sorry, I haven't heard your answer, please. Sorry, I haven't heard your answer. Not less than 1,000?
No. I said this patient is young. For this patient, it should be 2,000 to 3,800 because this is a young patient, 15 minus 15 diopters we are choosing. So for older patient, 1,500, more than 45, it should not be less than 1,500. Okay. Okay, so tell me one thing. What is the advantage of having this phakic IOLs over other procedures like clear lens extraction or other? Can you think of any reason behind that advantage?
First of all, I shouldn't distort the anatomy of the eye, and I will preserve her accommodation.
Yes,
There is less
very
incidence
important.
of retinal detachment and cystoid macular edema with phakic IOL.
Very good, very good. Any precautions during procedure you want to take?
I should be somewhat cautious with the endothelium and the lens, her lens.
Lens, you won't touch that. So despite everything, what are the complications you can have after phakic IOL? Like, what are the problems we still can have with phakic IOLs? One we told about
I still have the endothelial damage, pupillary blood glaucoma, retinal detachment, cystoid macular edema. I can have the complications of refractive surprise of I can't if I haven't calculated the IOL well. Also,
so let me stop you here. You are going to put phakic IOL into the eye of a myope, okay? And let's say that person also has some astigmatism. How will you choose how much IOL you want to put into that? Like for myopes and for hypermetropes. Is there any way we choose the right number? We are talking about number.
I can't get the question, but I think we could we should guide the patient for emmetropia.
We basically calculate spherical equivalent, right? If spherical equivalent and without. So yes, we find that. Okay. So sorry, I was mixing it up with something else. Okay, you're right. You're right. Okay, so we have done the complications as well. There can be pigment dispersion, and most important is there can be some loss in best corrected visual acuity, even with phakic IOL. So we have to prepare, but more or less these are safe cases. These are phakic IOLs are very good if done properly. So last two questions. I think, yes. Anyone wants to take this? This is very important. Look, this question is very important because you need to know everything about keratoconus. This is about cataract surgery in a case of keratoconus.
Yes,
so
okay.
I'll read, anyone can take. Okay. So the question is, a 45 years old man was diagnosed to have keratoconus at the age of 26. Okay. His record shows that his best corrected visual acuity has dropped from 6.9 to 6.36 in the right eye and from 6.12 to 6.24 in the left eye. He has bilateral cataract. He has very thin, lean build. You are considering this patient for cataract surgery, but what are the things you want to rule out or you want to consider before you start this patient preparing for the cataract surgery?
Okay, this man was bilateral cataract in this young age, and this refraction and the history of keratoconus was very thin, lean build, so I can diagnose it as Marfan syndrome.
You
So
want to rule out, basically, not just on. Yes, you're right. Your thinking process is right. Thin build, lean build mean you have to think about patient may have Marfan's. So what precautions you want to take? You will ask in the history, and what is important from your cataract surgery point of view? What things you need to know?
Okay, first I should examine his eyes carefully and see if there is any signs of ectopia lentis or if there is any signs of retinal degenerations or retinal detachment before proceeding for surgery. Also, I can do some investigations like UBM to detect the status of the zonules, if there is any zonular weakness or zonulosis. Also,
Good.
ultrasound for rule out presence of retinal detachment.
Perfect. Very good. And systemically, what are the things you want to consider?
Yes, for his systemic condition, I should liaise the internal medicine and the cardiologist for any signs of cardiovascular compromise.
Okay. So you want, very good. So important thing is you will consider the systemic conditions and do accordingly. Now let's say we have ruled out everything. There is no zonular dehiscence. It's a normal case of keratoconus without any systemic problem. No marfans. Okay. So now what next? You are going to do the cataract surgery. What are the challenges you will expect in this patient?
First,
Patient is very keen about a very good refractive outcome. Okay. So what is the first thing you will tell this patient? And outline your treatment plan.
I should counsel the patient about the refractive status of his keratoconus, and it may cause some challenges for post-operative refraction status. And there is also will be a challenge in biometry to get key reading. So we can use true K reading, or I can depend on the key reading of Pentacam. I also can use some formulas which less dependent on key reading, like Pareto Universal 2 formula for measuring IOL power.
Good. Good. So basically, you are not promising any excellent refractive outcome out of this surgery because you expect there are some challenges in doing the biometry. Is that so? Right.
Yes.
So can you tell me, so you said that you will do Pentacam and you take the readings despite that. Now you have done the procedure and still there are refractive surprises. What is your aimed refractive error which you would like to keep? And if there is a refractive surprise, what can you do about that?
Tell me the first question, please. Again, please.
In a case of keratoconus, okay. So first tell me, what kind of lenses IOL patient wants to have a multifocal IOL? What is your advice? Can this patient have multifocal IOL?
For patient with keratoconus, I advise to insert monofocal IOL or adjustable IOL to avoid post-operative high astigmatism.
Multifocal IOL is absolutely contraindicated. Multifocal IOL, because that patient will have. What?
I just said monofocal. I advise the patient to insert monofocal IOL or adjustable IOL. Yes.
Okay, can you use toric IOL?
Toric IOL has some disadvantages like glare and halos, and I think it may be increased with progression of keratoconus.
Okay, good. I think you have summed up it really nicely in first go. So very good. So keratoconus, in keratoconus biometry, you should be absolutely clear that you will use which formula to use, latest generation formulas, and the problems in biometries. That is can be either by using Pentacam, the K values, most appropriate K values, especially they should be in the pupillary axis. So perfect, you have done really. So what will be the refractive? I was saying that you should usually aim for myopic shift in keratoconus. Okay, so this is almost second last question.
Ma'am, I had a question. Hello, ma'am.
Yes. Yes.
I had a question. Is toric IOL contraindicated in keratoconus with cataract?
No, it's not. Look, In toric IOL, you have to see if you have to, in any case of keratoconus, cataract surgery in a patient of keratoconus, your first should be that I would like to assess how much the grade of keratoconus in that patient. Okay, if this is mild keratoconus, well controlled with glasses, multifocal is contraindicated, but you can use, and there is not marked irregular astigmatism, you can use toric IOL. Not multifocal, but you can use toric IOL, which will correct quite astigmatism, but don't promise very good outcome. Toric is not contraindicated, multifocal is.
Thank you.
Be very clear.
Doctor, I have a question, but about this, the last case, it is Marfan, so it has a high probability of subluxation. So still we can implant IOL, toric IOL?
You have to assess that. In fact, the first part of the question was, you have to carefully assess a patient. If a patient comes with keratoconus, so in keratoconus, first you have to see what is the level of number one keratoconus, number two, is there any associated systemic problem? So she, Dr. Isra mentioned all these in detail, that she will look at the zonules, she will see what kind of problem. If it's a perfectly normal case with mild keratoconus and you think there is no zonular dehiscence, then you can put toric IOL. Otherwise, these patients are okay with monofocal IOLs, because you have to tell them that they may need RGPs or glasses or anything after the procedure. You can't like promise any very good refractive outcome for these patients. Okay, so choose the patient carefully. So the prompt takeaway from this case was that don't just get stuck on keratoconus, think about other problems in the eye as well as systemic problems. Like if you miss that, that can cause problems. Rest, you all know how to find out, do biometry, or all of you are very proficient. This question, anyone can take this and tell me what do you see?
Okay, ma'am, I'll take this.
Okay. Kiroprash,
Yeah,
what do you
so
see?
ma'am, this I'm seeing the cornea picture under slit lamp with the magnified view, and I see that there is a flap. Most probably this is a post-LASIK flap, and I see that the patient is also having some keratitis, some haze in the corneal stroma, which can be diffuse lamellar keratitis, like a sand of Sahara. So my diagnosis is
so this is a case of, so I'm giving you the scenario. This is 4 days post LASIK picture of the eye.
Yeah.
So your diagnosis is, this is
DLK
probably.
Yeah.
Okay.
Yeah.
Any other differential you want to keep in mind?
Other differentials can be laser burn, and
really,
it can be
okay.
some
Okay, so what
infection,
is the treatment? So this is yes, keratitis, infectious keratitis.
Yeah.
One
infectious
more,
keratitis.
very important. One more thing. Give exactly this kind of picture. This is very important. I want you to say that. Okay, so what is the treatment? So okay, I'll ask you a question and you will automatically find out. So what treatment you will give to this patient?
This patient will need the frequent steroids.
Okay.
Along with the antibiotic, steroids, and lubricants combination has to be given. Yeah.
Can you grade DLK? Do you know how to grade DLK?
Exactly. I mean, it starts from the periphery towards the center. So it will. It is like between. I don't exactly remember, but it is
so
something.
Grade 1 is just peripheral. Okay, grade 1 is just restricted to the periphery, 1 to 2 millimeters. If it is coming into the center, that is grade 2.
Yeah.
Grade 3 is total scarring, and grade 4 is melting. So basically, grade 1 and 2 are important. So this is involving the center almost. So it's grade 2. Okay.
Yeah.
So you have graded that. You have increased the steroids and antibiotic. First, tell me what can be the cause of DLK during what may have gone wrong during the procedure, which had led to this DLK?
This can be because of the more laser burn. I mean, the power was more, or the burn has happened, or maybe some fibers have gone, some foreign body or something.
Look,
Or
laser
IOP,
burn is look. Heba or Arshi? Anyways, look, doctor, there is never laser burn in LASIK. There is no laser burn. So this can be anything entrapped under the first causes. Sometimes your body immunological reaction to the laser. Body
Yeah.
responds like that. Or it can be something entrapped under the flap. It can be oil. It can
Yeah.
be
Okay.
blood from contact lens use or a small microliter drop. Some fiber, even fiber don't cause that kind of reaction, but that can also happen. Or it can be infectious keratitis. Okay, so you are giving steroids, topical, right?
Yeah. Yeah.
Can you give oral?
If it is severe, oral can be given, but topical is mostly
Okay, so you have given
topical
it
will affect.
for 5 more days and condition is worsening. It's not improving. What is
Then
the other
it can
thing you
be
can do? It can be
subconj injection, and
of what?
the pressure has to be checked whether it is high pressure also,
Yeah.
because sometimes increased pressure can lead
So
to
Dr.
corneal
Ashi,
edema
that
and
was the
trap fluid.
thing, that was the third differential which you had to
Okay.
consider. Okay, please don't forget
Okay.
that, because you are giving steroids. So how will you find out in this case? How will you find out if it is high pressure or DLK? How will you check the IOP in this case, in a fresh case of LASIK?
IOP can be checked with the tonopen,
But
and
that is not
anterior
reliable because you have to cut the cornea. So it's not reliable. So you want to see the fluid
also
space between the flaps. Is it
fluid
so?
space in the
How
anterior
can you
segment
find it?
OCT.
Yes. So this is OCT.
Yeah.
Can you see?
Yeah. So this is showing the fluid in between the layers.
Now
that
what
black
will be?
color.
So you have given steroids and condition is worsening. What will you do now?
So now our aim is towards controlling the pressure.
How can you do that?
We'll start aqueous suppressants, or no, we will start this brimonidine, like alpha adrenergic agonist.
But what is the
And
cause of high IOP in this patient? What do you think?
Steroids.
So you have to stop
When
steroids. So you have been
steroid
giving
is
the
needed.
wrong treatment. So whenever you get a case
Yeah.
of DLK
Okay.
like this,
Yeah. Yeah.
most probably it is DLK, but this
Yeah.
can be high IOP. If a patient is presenting after 5 days,
Yes.
it can be
Yes.
high IOP. So it's better you say that it can be DLK, it can be infectious keratitis, or it can be high IOP. I would like to distinguish these things. Either IOP, you can take IOP, but if that is unreliable, or you can give sometimes in clinical practice, we give steroids and patient is not improving, you go for OCT, you look at the space and you stop. Exactly opposite treatment. You stop steroids, pressure lowers down, then it clears. Okay. So this question was meant for that you don't miss whenever there is DLK. There are two opposite entities that you have to keep in mind. Now here is the last question. This is not really related to
Ma'am, please,
like
I want to
refractive.
ask about something.
Yes, please.
How can we differentiate between both DLK and steroid induced on OCT?
How can we differentiate?
Yes. Is there
Look.
any difference on OCT?
Yes, look at this. This OCT, this is a flap interface. Forget about this black line. This area, you can see this line. This is actually flap interface. Okay? Okay, Dr. Isra? So basically, there shouldn't be any gap between that. When there is this black area is fluid. This is fluid is because of increase. This fluid space is because of increased IOP. Okay, so on OCT,
so fluid means there is a high IOP, not DLK.
Yes. So this is high IOP, right? Right. Okay, so in DLK there won't be this fluid space. So there are two ways you can mention. You can treat it like randomly, like you give increased steroids, it's not improving, you reduce steroid and start adding anti-glaucoma medicine, which I usually do. I hardly do OCT. But from exam point of view, the important is you must keep in mind that whenever there is corneal edema, you have to keep in mind two opposite entities. One is IUP and DLK, because their treatments are absolutely different from each other. Okay, this is the basic takeaway from it.
Okay,
right?
thank you.
So this is the
Ma'am,
last.
in place of steroids, what we will give then? We will give cyclosporin.
You give non-steroidal and anti-inflammatories. You reduce that.
Okay.
So you instead of that, I give Nevanic or anything like non-steroidal anti, because the cause is this fluid. It will settle down with that. It will take some time to settle down. This is the last question. This is very important.
Yeah.
I will take it, Dr.
Okay,
Asma.
Okay, Dr. Asma. Okay, so a 12 years old boy with myopia of -6 is brought to you by the parents, and they're worried that his number is increasing very rapidly. They want to either remove the glasses, or they want that there should be some way to stop this process over here. So what is your response to the request, and what treatment you can offer to them?
Okay, so the important thing is this is a young boy. He's only 12 years old and has got a high myopia of -6. So if the parents, they want to remove the glasses, so first of all, the parents would ask for any refractive surgery, to which I will respond that this age is not suitable. At least he has to wait till he's 18 to 20 years old. And in the meantime, I will ask or counsel the parents about certain lifestyle modification in that boy. He should be more like outdoor, encouraged to have the outdoor sports, and decrease the screen time. And for that, he should be like, and for the glasses, he needs to be under follow up at least after 6 months. And to decrease, the main aim is to make this myopia non-progressive, because it's a growing age of a boy. He's only 12. So I can tell the parents about certain, first of all, this outdoor sports. In addition to that, there is such certain like atropinization can be advised, like 0.01% can be given to this patient to decrease the progression. And there is also another like ortho K treatment we can go for that, in which this because he's a 12 years old, he can use the contact lenses, and the main and there are these DIMS glasses, which mainly decrease
Very
the
good.
myopia.
Good. Asma, you have started really very well. Good. I have two questions. First,
Yes.
atropine, you are going to give 0.01%. At what
Yes.
time? At night?
Yeah,
So
at night.
So at night. So what problems patient can have with atropine? Number one.
He can have like glare and there, because of the dilatation of the headache also, and uncomfortable.
What is the mechanism by which atropine reduces this? Like, is it
By
possible calling it stopping progression is like a stretch? You could say we can like try to reduce the speed of progression, because so what is the mechanism by which atropine works?
It works by in muscarinic receptors. It acts and decrease the accommodation, which is said to decrease the progression of myopia.
Okay, good. Okay, so you said ortho K. How does ortho K treatment work? How does that?
Yeah, it by using the contact lenses at night, it flattens the cornea throughout the night. So in the morning, when it is removed, the cornea remains the flatten and improve this minus number, and it will decrease the progression. But for
will
that,
is this change permanent?
No. For that, he has to use it on a permanent basis, on a daily basis, not permanent, sorry, on a daily basis, because otherwise it will reverse back to its original shape.
So ortho-K is not really a treatment to reduce the progression, is it so? Do you agree?
No,
It
no, it's not a
temporarily
treatment.
modulates.
Yeah, it's basically if we can't like give the refractive surgery at that time, so it's a temporary measure.
So
because
so it should be clear for everyone listening,
because
ortho-K is not the treatment to stop the progression. This is just a temporary measure we are giving. If you want to give that. Okay.
Yeah,
Mhm.
because people want to the glasses, so we can give them an option that up till 18 to 20 he can go for that, and after that we can go for refractive surgery, femtolesic or anything.
Okay, so patient returns after a few days that child is having headaches and he's unable to go to school and everything. Patient parents are willing to go more like any length, more expensive options or newer options. So any new technology you want to advise?
Yes, so then in that case, though it's a quite expensive option, but like these defocus glasses, which are available, in which the main aim is to defocusing, like making the peripheral vision blurred and the central vision clear. And there are like different type of glasses for that, like DIMS glasses, that is defocus integrated multifocal segments are introduced, and then they because of that they make the peripheral vision blurred, so that will also help him in that.
How does that although this is a new technology, but from academic point of view we need to know. So these are new generation glasses. There are 4 types, right, Asma? So one is DIMS, second is
DIMS, that is
HALT.
I think HALT, yes, DIMS, HALT, bolt also.
HALT is highly aspherical lenslet target.
Yes.
Okay. Third is CARE.
Yes.
CARE, cylindrical annular refraction element. And fourth is DOT. You just need to remember 4 names. Okay. All those listener. New generation glasses, they are DIMS, HALT, CARE, and DOT. And their aim is, as Asma has told, center area is clear and peripheral is blur. Now, Dr. Asma, how does this technology, by creating peripheral blur, how does it reduce progression? What is the theory behind that?
Mainly, I think the theory behind that is when the peripheral vision is blurred and the patient is looking directly from the middle, so he uses less of accommodation.
Yes, he uses less accommodation. Look, before when we are telling a person lifestyle changes, we are trying to reduce the accommodation. There is a 20-20 rule. 20-20-20 rule mean 26 minutes work, then 20-second relaxation, rest, and then 20-second looking far so that you relax the accommodation. Now these DIMS and all these classes, they work on this theory that if you create a defocus, retina will move in that direction. Like if you create myopic defocus, retina will move slightly toward it. This is all happening at microcellular level. It will slightly move towards myopic defocus, which is in front of retina. So it will slightly reduce the axial length. Similarly, if you create hypermetropic defocus, mean you are focusing it behind the retina will move in that direction. That's why use of screen time, it stimulates accommodation and there is aggressive progression of the axial length. That's why all these new generation glasses are based on this principle. By creating defocus, myopic defocus, not hypermetropic, you are basically trying to move the retina towards that. So since child is wearing it all the time, it's getting that stimulus, axial length progression is reduced. So Dr. Asma, obviously you can't prescribe these new generation glasses to everyone, right?
Yes.
So what are contraindications?
Contraindications, I think can be strabismus, and it can be like anisometropia if there is a difference in the refraction more than 1.5, I think.
If there is
And
amblyopia,
amblyopia, yes.
and if there is decreased contrast sensitivity. So you won't give glasses, new generation glasses, if there is squint, amblyopia, there is marked anisometropia, and there is reduced contrast sensitivity. So these are contraindications. And sometimes we can combine both these procedures, atropine with new generation glasses, and they reduce to some extent. Okay, so I think that's enough for today. Very well done. Very good. Very good. Any question? Do you have any question about any question so far?
Yes, madam.
Ma'am, can you please again tell what are the 4 glasses? And this you told about the name Tim's Heart Care and dot.
DIMS. First is DIMS. 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 DIMS is
Okay.
defocus. In everything we are creating blur. So remember, DIMS is defocus incorporated.
Yeah.
Multiple segments. Okay. This is what is central area is clear, and there is honeycomb lenslets in the periphery. Central clear area and honeycomb lenslets periphery in the periphery, which cause defocus. So one is DIMS. Okay. Second is halt. Like basic technology is same, but with slight difference. Halt is high aspherical lenslet target. Here what happens, there is central clear area, and then there in the periphery there are aspherical lenses in the periphery.
Okay.
Yes, clear center, because I have to remember that. So aspherical lenses in the periphery. So again, central clear, and they are creating in some other way. These are different companies which have made these glasses. Otherwise, they can all go with one technology. So basically, this third is care. Care is cylindrical annular refraction element.
Okay.
As you can say, it is using cylindrical elements. So central clear, they have peripheral cylindrical elements which are creating that is defocus. And finally is dot. DOT dot. Diffusion optic. Diffusion optic technique.
Okay.
It created like it also develops decreased control of okay. So dot basically reduces the contrast of cones. So basic technology, you need to know just the names, and principle behind that you keep the central area clear and you create myopic defocus. Please remember, myopic defocus is very important, because by creating defocus, you are basically stimulating the retina to move towards that side. There is some say there is choroidal thickness, some say it slightly moves in that direction. So at least it prevents operation. Okay, and it is not yet approved for hypermetropic shift. So it's only used for myopic. Just 4 to 6 year studies are available. It's a new technology compared. Okay.
Yeah. Okay. Thank you.
I think we have done enough, all the important topics. So
I have
yes.
Is there any type of lenses like the inlays for presbyopia that remodel the cornea for children?
For
something like inlays.
Corneal inlays?
Something like it, but I can't recall the name. That remodel the cornea.
Okay. Are you that is for keratoconus? Corneal inlays, rings, to remodel the cornea. That is for keratoconus.
Not for myopia?
For myopia. That is for myopia. For keratoconus.
There is something it's written in the new Kansky that for presbyopia we are putting this in days. We just yesterday saw and we were discussing this thing even for presbyopia. So I don't know. We have not seen that. So
I haven't. I will search it and I will let you. Okay, I'll read that.
Thank you.
I'm not familiar. Okay. So
yes.
Okay. Best of luck for all exam goals. If you
Thank
have
you,
any
sir.
question, you can ask me. Okay. So
Yeah, thank you so much.
Thank you. Thank you.
Thank you, madam. Thank you.
Thank you.
Thank you. I think we'll close. Thank you so much, ma'am. Good day.